We shall now go on to our next speaker, another very dynamic surgeon, Dr. Rakesh Shakya, who's the chief consultant and head of the Department of Glaucoma, and also a senior consultant cataract and intraocular lens services from Sadhguru Netra Chikitsalaya, Chitrakoot, and he has another interesting case to show us. Yes, on to you, Dr. Rakesh. I think Rakesh's video has to be shown from, okay, here. Then
thank you, ma'am, for the giving the opportunity, and thank you, Rajan sir and Prakash sir, to actually thank you. So I am presenting a video of 38-year-old male and the history of the trauma 2 years back and the temporal subluxation 6 clock hour with anger recession 1 clock hour. Initially, IP was at 26 millimeter Hg. So my video is running or not?
No.
Yeah. Now it is running.
So this is the traumatic cataract, and as I told initially, so I make a two side port initially, and then main port with the help of the side port knife, and then main port with the 2.8 incision, and put the visco. The capsule access is done with the help of the cystitome, initiated with the cystitome and completed with the Atrata forceps. It is about the 5.5 mm. And then try to actually capsule slightly become slightly elevated, and then we saw the vitreous slightly prolapse. So I cut the vitreous and then make a side pocket for the suturing eyelet of the Shioni ring, and then I make a 3 capsular hook to stabilize the bag in the area of the zonodialysis. So initially then job becomes slightly easier, and then rotate the nucleus and divide the nucleus by the stop and chop technique. And then one by one, I actually emulsify the piece. After the emulsification, removal of the cortex is done. So I just saw the vitreous also prolapse. So I just lose the this iris hook. So suddenly the capsule is shifted opposite side. So cut the vitreous again, and then put the visco, and then try to put the Shioni ring in this case. Slightly enlarge the side port, and then Shioni ring in that. And then I saw the Shioni ring is go into the vitreous cavity. So this is the disaster is done. So I think, and then cut the vitreous again, and then just again actually try it. So the Shioni ring I tried 4 times, but I unable to put in the bag. So I always actually so I actually decided to put the another Shioni ring, another standard CTR in the bag. So actually when I dialing the another CTR and then keep the trailing end of the standard CTR in the at the side port, and then try to remove the Shioni ring from the vitreous cavity. And then after that, I actually very unable to come out the Shioni ring and retrieve this Shioni ring. And then, but I try again, done. So, and then after that, we actually just engage the leading trailing end, and then comes out the Shioni ring again, and do the vitrectomy again. Then trailing end of the standard second CTR is implanted, and then again Shioni ring implanted. So this time is good, very good. But the picture abhi baki hai, because there the one disaster again is actually happened. The suture was broken actually. So why this reason? Then I sought how can manage this case. Then I actually try to take the another suture and try to pass from this leading the anterior eyelet from the Shioni ring, and thus just pass it through this anterior eyelets, and with the help of the another 26 gauge needle, and then suture it with the sclera. And the 2 ends of the suture is actually pass out from this scleral pocket and suture it. So I actually in this time I feel this is a bag is inflated well, and then the suture is tight with the 5 to 6 knot, and then I implant the oil in the bag. And then the main port is actually this is the scleral pocket also suture because slightly elevated, and then the first post operative very good, and after 1 month he get the vision is 6.6 I don't know how can, because the patient was actually young, so it get the good vision. So thank you so much, ma'am. Actually, I presenting this video because my management may be slightly wrong, but you are all are the experts, so you can give the better opinion to how to manage the case in the better way. Thank you, ma'am and Mohan sir.
Very challenging video, and I knowing you and having watched your different surgeries, I know you can bail yourself out of any situation, Rakesh. But just a thought I want to ask Dr. Rohit. Could he have left his capsular hooks in place? The point when he removed the capsular hook, there was vitreous already there. I think it came forward and increased the area of dialysis. Could he have kept the capsular hook in place till he placed his CTR? Or
Absolutely. Yeah, I think it was all is well that ends well, and the video shows his class.
yes,
Despite all the challenges, he was able to get through to the finishing line.
yes.
I would have done it slightly differently right from the start. My site of incision would not have been where the dialysis is.
Yes.
I would have been away. The initiation of RAKESH also would not have been there. It would have been right across. Because when you are initiating in the area closest to the area of zonular dehiscence, that puts more stress on the zonules. To be on the safer side, you should be farthest away, and the initiation should be towards the area of dehiscence, not away from it. Because that puts more stress. And the capsular axis should have been centered like that. And capsular hooks, definitely you used, you did vitrectomy at the right time, because the vitreous, that was further exaggerated by making the incision there. And, with the change in the dynamics, the vitreous was coming out. So triamcinolone could have been used by, having incisions at a different place. While inserting the CTR, the CTR insertion in whenever there is a zonular dehiscence, more than 90 degree, the insertion of the CTR has to be such that it should start from the area of intact zonules and then move on to the area of zonular dehiscence. You can do anyway if the zonular dehiscence is less than 90 degree. Here, since it was more, you could have gone, it was going, the direction was anti-clockwise. You could have made it clockwise so that it should have gone from the area where the zonules were intact and putting less stress. And I would not have removed the capsular hooks. I would have put in the CTR slightly, before, because the biggest saying is that it should not be later than what it should be. So before the last nuclear fragments were about to be taken out, I would have, implanted the CTR and provided a horizontal support in addition to the vertical anterior-posterior support, which was being provided by the capsular hooks. But how you managed when you broke the suture and how you went in, hats off to you.
Yes.
Thank you. Thank
And
you. Thank you, sir.
could you have thought of placing a CTS instead of a CNE ring altogether, a CTR and a CTS?
Absolutely, absolutely, absolutely.
Yes, ma'am. Actually, I planned to initially we put the CTR first, and then actually followed by the CT segment. So this will be maybe the better way. But in this case, actually, we have the CNE ring at that time. So I put the CNE ring first, and then actually when I see the vitreous is prolapsing more, then I put the CTR.
I think no, the main thing is not to make the incision at the area of the dialysis, because
Yeah,
going to the phaco probe, you are hydrating the vitreous there.
Yeah.
So more vitreous would come.
Can I add one thing, Chitra?
Yes.
I think the incision should be aware. Rohit said very nicely.
Yes.
First thing is, when you have a subluxated cataract, as soon as I put the incision, I put viscoat in the area of the subluxation. Then I put tricot. Always remove the vitreous first there. Okay, you can go pars plana, you can go limbal, whatever you are comfortable. This is the ideal indication for pars plana. Go through the pars plana, have the anterior chamber maintainer, and then you can go through the pars plana, remove the vitreous which is prolapsing out, because the tricot will be able to delineate the vitreous. And then put the capsular hooks. Then you proceed. Because every time you have vitreous there, this problem is going to come. So take care of the vitreous first, put the capsular hooks, and then, do the RAKESH, put the capsular hooks, and then go ahead with the surgery. All other things he has done so well. Hats off to you, Rakesh.
Yes.
Thank you, sir.
Dr. Ramurthy, I think everything has been covered. You
I
have
think
to add.
just very well managed. I mean, hats off. He was in a very difficult situation. He came out of it so well. But today, with the availability of Hammer segment, as others pointed out, the combination of an endocapsular ring with the Hammer segment would be the way to go. The CTR is always, the Sionis ring is always a little more difficult to maneuver. So yours is a traumatic cataract, and this was not, though the large subluxation. The endocapsular ring initially would have provided enough circumferential support. You could have completed the surgery. Then subsequently, you could have slipped in just before implantation of the intraocular lens. You could have slipped in a CTS, which can be done in a more controlled manner to fix the capsular bag onto the sclera. But otherwise, I think all points have been already covered. The only other thought is that, nowadays, the more and more we are believing that putting in a 3-piece lens in the sulcus and creating an optic capture in these subluxated lens further stabilizes the bag, and apart from the devices that you have already put in.
And of course, the final thing is you could have done remove the cataract and placed an iris clip and got away without doing any of these things. So we shall go on to our next speaker. Anyway, hats off to you, Dr. Rakesh.
Thank you. Thank you, ma'am.